Welcome back to Chapter 12. We pick up where we left off on arthritis and joint pain, where we're going to be talking about rheumatoid arthritis, a class of drugs known as DMARDs, disease-modifying anti-rheumatoid drugs. Moving on from the glucocorticoids, we have the disease-modifying anti-rheumatic drugs, or DMARDs. These are really interesting because they are becoming much more specific, fewer side effects. They're much more flexible in terms of how we can use them in therapies. So you can use them in low doses early on. You can use them in progressing disorder and try to stop the progression. As I mentioned earlier, once the damage occurs, we really don't have any way to undo the damage. It's functionally irreversible. So we want to head it off of the pass as early as possible. That's why the remission goal is so prevalent in rheumatoid arthritis. They don't have analgesic effects. They are just simply stopping the progression of the remodeling and damage to the joints. And they're slow to act. They are slow acting because you're dealing with slow genetic effects in response to the signaling in these pathways. So you will often need other drugs like corticosteroids or glucocorticoids to bridge while these things take hold. So here is a sort of an overview. So we have the erosion in cartilage and bone, the joint damage down here. And so DMARDs are trying to stop it from this direction, whereas glucocorticoids are trying to stop it from the osteoclast and fibroblast side of the equation, if you will. One of the lead drugs is actually a sulfa drug. If you've ever heard the word sulfa, this is what they're talking about. It gets converted into a couple of different forms, one of which is excreted rapidly and doesn't do a whole lot, and the other is into this 5-ASA, which is the active metabolite. This is an inactive metabolite. This is the active metabolite. This thing can inhibit cyclooxygenases, lipoxygenases, platelet activating factor, not unlike aspirin. But it will also inhibit the release of TNF-alpha and IL-1, so that's where the anti-inflammatory aspect of it is really kicking in. Another drug, and again, I'm just kind of keeping it here. I'm not going to talk too much about it. There's more here than I really want to discuss. It's chloroquine and hydrochloroquine are good for DMARDs for I keep saying I want to say retinoic acid, but that's actually rheumatoid arthritis and in lupus because of its ability to stave off some of the cytokines release. We don't really understand exactly how it works. It takes a while for it to kick in, but it's a useful drug for more than just rheumatoid arthritis. Methotrexate is what we would call in cancer circles an anti-metabolite. It is blocking the ability to synthesize DNA. Dihydrofolate reductase, which is an enzyme involved in turning folate in doing DNA synthesis, gets blocked. So it's an anti-metabolite. We see methotrexate being used in cancer, and we see methotrexate being used in rheumatoid arthritis. It's depleting the nucleotide pool, which then causes the cells to die. So it's going to affect rapidly dividing cell populations, and white blood cells are rapidly dividing. So you're preventing active white blood cells from coming around because there just aren't enough of them around. So you're blocking nucleotides, but that means it's going to have effects on other rapidly dividing cell populations. So they might have anemia. They will certainly have hair issues, GI, nausea, that sort of a thing. So here is some of the advantages. It's very systemic. It can be used for any number of immune autoimmune disorders like psoriasis, SLE, etc. But again, where you're going to see the disadvantage is because it's a general cytotoxic effect, you're depleting nucleotides, so dividing cells are going to be affected. GI, rapidly dividing cells. Liver has dividing cells. Bone marrow, pneumonitis, I don't know, that may be just because of the immune suppression. But one of the things right here that I have flagged, they call this a category X drug because for absolutely no reason would you ever allow use in somebody who's pregnant. And you're talking about an age group of 35 to 50, so pregnancy certainly is a possibility. And because it's depleting the nucleotides, it can lead to profound teratogenicity, that is to say, deformations or fetal death. That's why it's category X. It is completely contraindicated in pregnant women. I'm going to skip this slide. I left it in here because it's just another drug that's out there. It's also a nucleotide synthesis inhibitor, sort of like an anti-folate, anti-metabolite, if you will. Now let's get to some of what we call the macromolecule Tnf inhibitors. These things are very, very specific. These are engineered antibodies or specifically developed antibodies using specialized cells to attack the TNF receptor. You're sort of inducing an artificial Hashimoto's disorder. Hashimoto's is an autoimmune downregulation of the thyroid hormone. It attacks the thyroid hormone receptors and basically suppresses thyroid hormone function. Well, these guys are engineered to try to do the same thing with TNF-alpha receptor. Okay? And so we have different types of engineered antibodies. And very, very interesting strategy, and remains to be seen if we can even make them more specific. So some of the biologics that we look at, these engineered, we have some frontline ones. The problem with the side effects is that it may lead to some autoimmune type syndromes, including sort of like a multiple sclerosis or a lupus type situation, because these antibodies can potentially react in other places, inducing inflammation in those areas. And so we do see some of that. CHF, I'm not exactly sure why it would be, probably secondary to some autoreactivity that's not been weeded out of the antibodies. In here I just have some more of these antibodies, and then there's this drug out here. This is an IL-1 receptor antagonist, Anakinra. And there are some other ones. These are all meant to get after the signaling and some of the specific agents that are involved in rheumatoid arthritis. So here are the pages that we really want to pay attention to. Again, because you guys are not going to be the prescribing authority in these situations, we're going to want to be on the lookout for ADRs and ADEs. The issue with any of the rheumatoid arthritis drugs is that they are suppressing the immune system, which can lead to susceptibility to infection. Many are toxic to the liver. You might see some type 3 hypersensitivity going on with the anti-TNFs. So we need to have proper hydration. We might want to avoid some rigorous activities, especially with steroids in combination. You already sort of have a weakened immune system, maybe a little bit more fragile due to the drug administration, and so you can lead to bruising and injury that way with rigorous activity during that time. When dealing with gout, we're going to probably first be in on the treatment side, because you don't know you have gout until you have gout, if you know what I mean. And so treatment often precedes prevention, unless you have a family history of it or something. Certainly the NSAIDs are going to be a big thing to alleviate pain and swelling and discomfort in the patients, fairly effective along those lines. A really, really interesting drug that is not fully understood. I mean, we know some mechanisms. It's called colchicine. And I first encountered colchicine in cancer studies because what colchicine will do to cells is stabilize their microtubules. Now, that is not what I'm not convinced that that's the mechanism that's going on here, but somehow colchicine is blocking the urate crystals from depositing in the tissues. What it has to do with microtubules, I don't know, but it's a really interesting effect that it will prevent urate, and it's also a microtubule stabilizer. So I don't really know what's going on there. And then we have corticosteroids, which again are immunosuppressants and will lower populations of Ig, of eosinophils and mast cells and stuff. And then we have this last drug, which is called Anakinra, which is occasionally used in rheumatoid arthritis. Anakinra is an IL-1, interleukin-1 receptor blocker. So interleukin-1, which is way up early in the pro-inflammatory cytokines, can't bind to the receptor and can't activate inflammatory-associated cells. So let's move on now to a little more about the prevention of gout. If a patient has particularly severe or recurring gout attacks, then it will merit more aggressive therapy above and beyond just dietary and exercise modification. And so we're going to go after uric acid production and or excretion in the body. And so getting after production, there are two primary enzymes that are attractive targets, including one big one here called xanthine oxidase. And so there are xanthine oxidase inhibitors, and then there's an earlier step called using an enzyme called PRPP, which is also a potential target. And in terms of getting rid of uric acid, a drug that was once used to improve the efficacy of penicillin, called probenecid, will also block resorption of uric acid in the tubules. It will be resorbed. Uric acid can and is a metabolite that can be used in the body. So it will be brought back into the body through these transporters, and by using probenecid, you're competing with those transporters for resorption and thus forcing uric acid to be excreted. So looking at prevention, certainly increasing urination, breaking up the uric acid crystals, other types of therapeutic options that we really won't talk too much about that either block the absorption of uric acid in the digestive tract or facilitate excretion. And then we have so here's probenecid. It blocks some of these organic acid and urate transporters. So you can't bring it back into the body once it's filtered through the glomerulus. Then we have the xanthine oxidase inhibitors, allopurinol being one of the frontline drugs there. So let's talk about allopurinol. Allopurinol blocks xanthine oxidase, so you start with a nucleotide base called a purine, and it cannot form uric acid as easily. It can still form by some other forms of oxidation, but what it does is it sort of forces purines to be disposed of in alternate fashion, thus not forming uric acid. Now, some of the untoward effects of allopurinol. It's a very good drug, but it doesn't work well in some situations. One of the things that it can do, that allopurinol can do, is actually prolong painful arthritis of gout in acute gout situations. So it's not indicated during an acute attack. Allopurinol can induce rashes. It can affect the bone marrow. Because again, when you're metabolizing nucleic acids or the nitrogenous bases of nucleic acid, you're upsetting the ratios of these metabolites that are used in rapidly dividing cell populations. Allopurinol is also used in cancer, by the way. If you're looking for a break, this is a good time. We're going to shift topics right here. We've been going for a little more than half an hour. And so, normally if I were teaching this lecture in person, this is where I would say, hey, let's take a quick break, and then we can shift topics a little bit. Okay, starting back up again, we're going to move now to systemic lupus erythematosus, otherwise known as lupus or just SLE. It is an autoimmune disease. What's happening is the immune system is attacking healthy tissue all over the body. The symptoms are variable, but some of the more common symptoms are arthritis in the joints. Particularly, you see this in young people, so you shouldn't be seeing osteoarthritis that soon. They might have a mild fever, chest pain due to inflammation of the pleura and pericardium. They might see some hair loss, or you get this butterfly type rash. You get it right around the face. And so again, arthritis, maybe some kidney issues, but here's a good picture of that butterfly rash. And what's going on is we have autoantibodies attacking various tissues. There is no clean etiology for lupus. There seems to be some genetic component to this. There can be some environmental component to this. Women get this more than men. We often wonder if there may be a virus of some kind, but we haven't tied down exactly what's going on. But what's happening is it's leading to abnormal immune responses where cells are activated that trigger B cells to create antibodies that are autoimmune. You don't have the culling of autoimmune B cells like we have in what's called central tolerance. You don't get rid of the autoimmune B cells, and so the B cells mature, they develop these autoreactive antibodies, and we see the butterfly rashes, kidney disorders, and so forth. If left unchecked, it will spread and become more systemic over time. Could lead to renal failure due to the kidney damage from the deposition of antigen antibody complexes triggering inflammation in the glomerulus. Certainly, it's an inflammatory disease, so it will cause atherosclerosis, again, sort of accelerated by the autoimmune antibodies. So what are we going to do? We're going to use anti-inflammatory drugs. We're going to use immunosuppressants and anti-metabolites, not far away from either rheumatoid arthritis or gout. So that's what kind of brings these things all together, is we're going to use similar drugs that we've seen before. Because of the fact that lupus will manifest on the skin surface, a lot of conventional treatment is centered around the cosmetic reparations, if you will, like avoiding the sun, covering up the rashes and things that you see. And it's not to say that that's wrong. A balanced diet is always going to be good. It's just not getting at the root cause. It's really just sort of downstream. Certainly, you can downregulate cells locally or regionally, or more systemically with the oral steroids and anti-metabolites. Corticosteroids can be used. Again, these have a powerful immunosuppressant function, and occasionally the high doses, because if you have a really hard flare, it can be potentially life-threatening because it's affecting the heart and the kidneys. So this is one of those times when high-dose corticosteroids or other immunosuppressants might be merited. And this slide is a great sort of non-specific. It certainly is relevant to lupus, but it's also relevant to any autoimmune disease. So I would have something like this anytime you're assessing somebody in your care. or if there's a family history of it or so forth, you might want to refresh from time to time to keep your eye on these so that these things do not get out of hand, because it is a progressive disorder. Raynaud's phenomenon is curiously similar to SLE. It may be related. Well, what you see is a sort of a more localized effect on like blood vessels and so forth in the hands or distal appendages. And so it's a similar pathophysiology, antibodies binding tissues, only it seems to be a more peripheral, and maybe it's a very, very early stage. It's hard to say. I got this picture last summer in the Galapagos. I was snorkeling with some folks from Texas, and they both had this Raynaud's phenomenon that particularly manifested underwater because perhaps they had slightly lower oxygen, lower temperature or something, but they would get this very, very distinct bleaching and bluing in their fingers while they were underwater. It didn't seem to bother them all that much, but it was something to see. The problem with the drugs, again, here are the pages for you to take a look at. With therapeutic concerns of SLE and or Raynaud's, if it's being treated, would be that you're suppressing the immune system or you're suppressing rapidly dividing cell populations. The drugs do induce UV sensitivity, and that can be an issue. Another thing about lupus or in some of these autoimmune disorders is that these drugs that are listed here have a propensity for inducing lupus flares or lupus recurrences. And so it's one of those things that you'll just have to kind of have a general sense that if they're on other medications, that those medications may be contributing to the lupus phenomenon that they're experiencing. But the commonality that we've seen through almost all of these disorders, now gout doesn't really count, but certainly with rheumatoid arthritis and SLE and Raynaud's, we are seeing this sort of type 3 immune complex mediated inflammation in these disorders. So there's a common pathophysiology there. Our final condition in this lecture is osteoarthritis, which is considered a non-inflammatory degenerative disorder. That's not to say that inflammation isn't involved, it's just not as prevalent and overwhelming as we see in other disorders like rheumatoid arthritis. There seems to be a more nuanced imbalance between synthesis and degradation of the extracellular matrix in the cartilage, the spongy extracellular matrix. It's meant to absorb compression. Many of the extracellular matrices, like in tendon and so forth, are what you would call tension or type tissues. Well, cartilage is a more compression resistor. It bounces back from compression. But it's being destroyed, and that's leading to painful interactions between the bones. It is an age and use dependent disorder. People who have repetitive motions in their jobs or stressful motions in their jobs will often have osteoarthritis in those joints that they've been doing that in. But you can see a lot of people over 55 have some form of osteoarthritis. 95 over 65, so it's a huge issue. It's one of the leading causes of overuse of NSAIDs. You can see it's a very big problem just by the sheer numbers of people who have it. It often goes asymptomatic until we've progressed down to where the cartilage is very, very thin. My grandmother had total knee replacements, and she originally went in and they looked at her knees, and she was thinking, well, she only wants the one in the knee that hurts. And the physician, the orthopedic surgeon said, well, the other knee is actually worse, but for some reason you haven't felt it. And that's one of the issues here as well, is that people will do what they do, and they won't realize that they have osteoarthritis, and they're on this track until fairly well along into the progression of the disease. So comparing a healthy knee to a knee with osteoarthritis, what you're seeing is primarily a reduction in the cartilage between the two bones, leading to bone-to-bone surface interaction in these joints. And it is a progressive disease that will self-reinforce. And like I said, we consider it non-inflammatory, but that's sort of hogwash. It's just not overtly inflammatory. It's a more normal progression of inflammation, but it's unresolved. So we get tissue damage that causes cartilage damage and more trauma and release of inflammation that then triggers remodeling and additional damage. And so you get this recurring cycle of inflammation and damage and inflammation and damage, that sort of thing. So here's a normal joint on the left with your different surfaces. Again, we've pretty much lost most, or if not all, of the cartilage at this point, and we're seeing sort of bone-on-bone interaction. You may see some hypertrophy of the synovial membrane if you are looking at a high enough resolution image. And that can be, but what you don't see is the sort of remodeling of the bone nearly as much as you would see in the osteoarthritis, or the rheumatoid arthritis, excuse me. And so you can sort of compare it here. So here's your normal joint. You can see the loss of cartilage here and the bone-on-bone interaction. You don't see that in rheumatoid arthritis. What you're seeing is additional bone being deposited, so that you see a change in contrast on the X-rays, and so forth. So this is a rheumatoid, and this is an osteo. And again, why it would be considered as somewhat non-inflammatory is a little bit baffling to me, because we do see some of the same players that we saw in rheumatoid arthritis. It's just the way that the disease manifests and so forth, and the dependence on inflammation. You still see TNF-alpha, you still see interleukin-1 and interleukin-6. So it's similar to rheumatoid. It's just not as, it doesn't strike younger patients. This is the disease of older folks. And so mechanical trauma, sometimes genetics and other irritants will drive the initiation of rheumatoid arthritis, leading to activation of inflammation, immune cell migration, more chemokines, and so forth. Here's a nice comparison of osteoarthritis, and you can see age. Okay. This can begin at any time in life, most commonly seen in individuals over 50. It's a slow progressor. Rheumatoid arthritis is much more fast. So this is a nice comparison here. I recommend that you take a quick look at this and maybe find 2 or 3 of these things that you can recognize easily. But the treatment for rheumatoid arthritis, we call it the AAA: aspirin, analgesics, and acetaminophen. So one of these 3 or combinations therein. Beyond that, maybe avoiding use in some cases if it's possible. Try to allow the joints to rest a little bit, but that can be a sort of destructive pathway, because if they're not moving and out and about, then they can fall into a sedentary, progression. There are some there is progress on what are known as Visco Supplements. That is injections of biological-like material in between the spaces in order to relieve that bone-on-bone, that mechanical injury that is occurring with use. And so this is a growing field and has some demonstrated promise. Another direction that is quite popular in folks that have osteoarthritis is to try to supplement diet with molecules that are known to be prevalent in cartilage. That is to say, chondroitin, glucosamine. These are all are enriched in cartilage material, and there is some minor efficacy associated with glucosamine and so forth. But it's still pretty minor, and if you really want glucosamine and chondroitin, there may be less expensive and more delicious alternatives. So in addition to the pharmacologic treatment, there are surgical opportunities out there depending on the status of the joint. Anything from trying to repair the cartilage or reduce bone-on-bone impact to full-on total knees, total hips kinds of things. Basically, creating artificial joints that are not inflamed and painful. And there's non-pharmacologic treatment, like for instance, creating exercises and routines that avoid additional or recurring injuries. Astonishing how effective weight loss can be, because a lot of OA is in the lower extremities just due to impact. Walking the right way instead of driving your heel into the floor may be more of a kind of a cat's paw type motion where you're landing on the ball of your foot rather than on your heel. Orthotic devices can do that in some cases, not only for behavior and exercises, but other joints that may be suffering from this, and so forth. There's options out there, and the prevalence of it and the severity in some cases means that we're going to see a diversity of possibilities in the therapies. There's even now these stem cell mediated. What you're trying to do here is you're going to harvest stem cells from somewhere else in the body, whether it's liposuction, which would kind of address that whole weight loss and get the stem cells at the same time. You get these cells and you can feed them growth factors and cytokines that will cause them to differentiate into chondrocytes. And then you inject those cells into the knee, maybe with some matrix or something to help promote their growth, and it then will cause the cartilage to begin regrowing and then preventing that bone-on-bone interaction. So it's really, really cool therapy if they can refine it. There's a little bit of CRISPR and Cas9 is really helping with this. Those are gene editing tools. And so there's some really, really interesting stuff coming down the line where you can induce these cells. The problem is you don't want to get the cells to grow too much, and you certainly don't want them to grow too little. You have to find the just right, because too much could lead to a sort of tumor-like situation, and too little would be ineffective. And that's it for Chapter 12. Thank you for your time. Please do, as always, read the book alongside this. I know that I am and I'm trying to help you access the book in a better way because I do believe that this is a lifelong learning topic. I think it's important that you continue to expand your ability to read dense material, and this book is certainly dense in some cases. So do use the book to your best advantage. Use these lectures to your best advantage. Always take notes, and I will see you soon. Thank you for your time.